So, wait a minute. Did you have the same double take that I had when you saw that number, 105,000, 104,000 cases? That was for the U.S. only. So 104, almost 105,000 cases in the U.S. Actually, if you look at the Bing numbers here, the summaries on the left, I think they're a little bit behind the Hopkins numbers on the right. But we're at 600,000 cases, give or take a few, and I would say a few more than that. As many of us know, the U.S. is likely, the U.S. and especially Western Europe, both regions are likely to have better counting than other regions of the world. We probably have significant undercounting, places like Russia, maybe Africa, maybe some of the other areas. There's no question we are not flattening the curve right now. We are going up a major hockey stick, reflecting significant, huge transmission of cases over, or of infection over the past few weeks. So that's the summary in terms of the numbers. What about the topics for today? Vitamin C, the Harvard FAQ page, and testing quandaries. Significant challenges in the first and the last item. Vitamin C, this is a major debate that was started decades ago. If you haven't heard of the vitamin C debate, just look up Linus Pauling, vitamin C theory. Nobody would argue that Linus Pauling was a very smart guy. He's, as you hear over and over again, he's the only guy to get not one, but 2 Nobel Peace Prizes. But when I'm referring to the major debate that started again prior to COVID-19, I'm talking about mid to late 2019. There was a doctor in an ICU environment who took about 40 cases before and 40 cases after, and gave a group, again, of about 40 cases vitamin C. He said he got astounding results. So that tripped off yet another major debate about vitamin C. And this was not just in terms of prevention, this is in terms of treatment of people with severe disease. That's what the rekindled debate that I'm talking about today. We're just going to touch briefly on the Harvard FAQ. It's very, very basic. Again, I'm not going to spend much time on that. Mass testing quandaries. I have, as you know, I've been working with a group, a couple of national groups, a retailer and a logistics group, looking to set up national mass testing. It's been fraught with challenges, and I'll go into some of the challenges right now. If you look at the CDC guidance, and most of the states, their guidance is tier 1 only. Well, that may sound okay, but what is tier 1? That's pretty murky as well, and we'll go into a little bit of that. Yes, there's still problems with not enough kits, not enough PPE, but really those problems, at least if the shell game is not happening, and we know some of it is, those problems are beginning to settle out just a little bit. Political challenges, as always in an operation this big, are major problems, and logistical challenges, like how do you set up maybe not 1, but 2 patient portals or testing portals, which help people walk through a very complicated definition of tier 1, and then decide whether or not you can get the test. So why not just do mass testing? Why not do it like South Korea, maybe Singapore, mass testing, find those clusters, find those cases, find the transmission, and start putting quarantines around them. Again, it gets back to having enough test kits. So what you see is the Association of State and Territorial Health Officers, AASHTO, following the lead of the CDC, and the CDC, again, making recommendations that are fairly narrow in terms of tier 1. But again, having some challenges in terms of communicating exactly what a tier 1 is, number one, and then once you get up and rolling, actually enforcing tier 1. So a lot of murky challenges here. So we talked about the numbers themselves. Again, Clyde, for future introductory rollouts, if we list the US numbers, we should label which number that is rather than just leaving the 100,000. So vitamin C debate. As I said, this has been going on for years. It started with Linus Pauling. It was rekindled in 2019. 2017. And again, rekindled in 2019 with the sepsis and ARDS issue. What is sepsis? It's overwhelming infection in the bloodstream. What is ARDS? Acute respiratory distress syndrome. That's what usually kills people when they're in sepsis. And sepsis is ICU. I mean, if you've got infection with high counts of infectious agent in your blood, starting to drop your blood pressure, creating major, it leads to major shutdown and is very, very lethal condition. Usually the last Grim Reaper, the straw event that kills the patient with sepsis is infection, overwhelming infection and reaction in the lung. So why are those important? And why would COVID-19 rekindle all of this? We'll talk about that in just a second. But first of all, let's go back to that that article that re-triggered all of this vitamin C in terms of treatment. And again, let me just clarify here. There are more than one debate. There's a lot of debates about vitamin C. This one is just on treatment for severe infection, sepsis, and acute respiratory distress syndrome. You'll see they're trying it in New York. I think the governor of New York announced. So are we broadcasting again now? Okay. Okay, great. So I'm not sure, where did we drop? Okay. Well, to quote Jack Nicholson in, was it Jack Nicholson or a couple of movies? I'm back. Anyway, so let's go back. And thank you, YouTube. Thank you, StreamYard. And I think it's more of a YouTube problem. Let's go back and cover a couple of things real quick. We're going to talk about vitamin C, more the treatment debate. Intravenous vitamin C for full-blown COVID respiratory distress syndrome. We'll talk very briefly about Harvard FAQ. Again, it's very basic. It's something you can give to folks that are just haven't been living on this planet and don't know what COVID-19 is. And then some discussion about mass testing quandaries. Again, we talked a little bit about this is a very rapid, quickly moving situation. The last time I looked was just about a half an hour ago, and the Bing tracker was saying a little bit less than 600,000 cases. The Harvard tracker was saying a little bit over 600,000. So again, a reflection of how quickly that's moving. To go back to the vitamin.
Kindly share your screen.
Okay, thank you, Clyde. Ah. So, are we on and are we transmitting?
Yep, we are.
Okay. I'm not going to go back over what we just recovered. Vitamin C debate, intravenous treatment for sepsis and ARDS. Again, sepsis is overwhelming bacterial infection, which is lethal in most cases, like at least half of the cases. The final insult is quite often ARDS, acute respiratory distress syndrome, where this overwhelming blood infection creates, again, overwhelming infection in the lungs and inflammation, filling the lungs with water and making it impossible for the patient to ventilate, breathe, and get oxygen. Now, this specific vitamin C debate was rekindled back in 2016, 2017, when a doctor that runs an ICU in Virginia, Dr. Paul Merrick, did a brief study, very small study, and looked at intravenous vitamin C. So here's the study. It was published in Chest magazine, or the Chest journal. 47 patients in both treatment and control groups, no significant differences in baseline characteristics between the two groups. Hospital mortality was 8.5%, or 4 out of 47 in the treatment group, compared to 40%, or 19 out of 47 in the control group. The probability of that's obviously 0.001, which is 1 in 1,000, assuming that there was no bias, et cetera, et cetera. So as you see, the results suggested that early use of intravenous vitamin C, together with corticosteroids and thiamine, are effective in preventing progressive organ dysfunction, including acute kidney injury, reducing the mortality of patients with severe sepsis and septic shock. So that was enough to trip off yet a whole new series of debates about the role of vitamin C. This one not so much in prevention, this one in actual treatment of severe disease. Just as a comment, we covered the debates around vitamin C and prevention earlier this week, and basically there's some data out there. It's like 8% improvement in terms of prevention and or treatment. It appears to decrease symptoms for about 8%. If you go back and look more deeply at the research and the evidence around prevention, you find there are Cochrane studies. The Cochrane studies complain that, you know what, garbage in, garbage out, and most of the prevention studies are garbage. The ones that are there and are not bad are fairly inconclusive. So why so many bad studies about vitamin C? Why not a well-funded, very good prevention trial for vitamin C? Because who's got the money and who's going to be able to put the money into research on vitamin C for prevention? There's just not the kind of dollars behind it. So it's going to be a while before we figure that out. That's the prevention side. This is the treatment side. So after Dr. Merrick did his study back in 2016, 2017 and published this in the Chest Journal, again, it tripped off a whole new set of a firestorm of debate within the ICU community, the critical care community, about should we be giving vitamin C IV to prevent organ failure, inflammation, and vascular injury in patients with sepsis and acute respiratory distress syndrome. There were a couple of studies. One of them was called the vitamin study. This one was called the Citrus Ali randomized clinical trial. Now, what did they find? This was very interesting. The question is, can intravenous high-dose vitamin C reduce organ failure and biomarkers of inflammation and vascular injury among patients with sepsis and acute respiratory distress syndrome? They did a clinical trial and included 167 patients in the ICU with intravenous infusion of high-dose vitamin C versus placebo for 96 hours. It resulted in no significant difference. In what? That's the question. In things like inflammation panels, in the SOFA score, which is sequential organ failure assessment. Why did they do that? Well, they were afraid that they wouldn't see any significant change in death rate, and with a study of 160 rather than 1,600 or 16,000, and therefore maybe kill this debate too soon. They got the exact opposite results of what they feared. None of the continuous indicators like inflammation markers and the SOFA indicators. But then what happened? You look at death, and the deaths were significantly decreased. So then that just made this whole interpretation of this, this debate murkier and murkier. Their interpretation was, among these patients, the vitamin C did not significantly reduce organ failure. Dr. Merrick was asked to present. Now, it was about an hour-and-a-half presentation that I heard. It's in YouTube. You can find it. He was obviously very upset, very frustrated, and he had several different criticisms of the study. The major one being that they did not administer the intravenous vitamin C early enough. So where does that leave us right now? We've got a pandemic going on. It kills people by acute respiratory distress syndrome. What do we do? Well, you see a lot of trials going on right now with intravenous vitamin C and COVID-19. New York hospitals some of the New York hospitals are trying it. There's studies going on in China still. There are other studies going on. And what's the answer? Well, I don't think we have an answer to that. And so again, to get back to my style with patients, I give patients the facts. And then they'll say, well, that's kind of murky. What do you do? I'll tell you what I do. I went back into my pantry and I did find some vitamin C. I had been getting a little bit lax on it. I'm back to taking 2 grams of vitamin C per day. Now, if you decide to do that, just note that it can cause some GI distress. So be ready, be prepared. A couple of quick comments about Harvard FAQ. Again, the Harvard FAQ, you would assume would be very detailed, very broad, get into a lot of information. It just happened to pop up in front of me as I was doing some of my prep work for some of these presentations. And I have to tell you, I was a little bit disappointed. It was sort of like COVID 101. Again, sort of like if you haven't been living on this planet, haven't been hearing about details, it tells you what it is. And then it morphs into some questions for the university itself. So here's some of the questions that it asks. What is coronavirus? What is COVID-19? What are the symptoms of COVID-19? How do I prevent myself and others? So if you've got somebody who doesn't want to get into all of these detailed debates, that's maybe a good place to send them. And most of those people just are not spending much time on this channel, obviously. Again, then you get into Harvard University questions. What do I mean by that? Well, what do you do if you're an international student at Harvard? And what do you do about COVID? So again, probably not a whole lot there for viewers of this channel. The last feature topic I have for today has to do with an update for coronavirus testing. As I mentioned, the CDC and the most state health officers and territory health officers are still in line, and they're all saying tier 1 testing only. Well, what does that mean? We'll go into what tier 1 is, because it's really a little bit murky. Why tier 1 testing only when you have proven success in flattening the curve with countries like Singapore and especially South Korea? Bottom line is there's not enough testing kits. There hasn't been enough testing kits for week after week after week as this problem has continued to grow. And again, I think that's one of the major reasons that you see some of the problems we see in the US right now. Yes, we also have other problems. There's not enough PPE. The supplies for the kits and PPE right now appear to be growing. You've got a lot of shell game going on. I use the example, one of the logistics guys that I'm working with was at a very high level of logistics in terms of the US Army. He was a general in the US Army in one of the theaters, and he said, right now this reminds him of a time when they were looking for a thing called a lowboy, which is a major tractor trailer for hauling huge equipment. They were surprised to see in a tiny area, it looked like they had about 40 lowboys available. Then when they started looking more deeply, yes, you had about 40 different companies saying they had lowboys, but it was the same lowboy with 40 different magnetic signs on the door. So you've got a lot of that going on right now, but it does appear to be settling out. Again, we've covered that a couple of times. A lot of local home heroes, engineers designing do-it-yourself face masks, a lot of local seamstresses getting back into using Tyvek to build, to create gowns, using other equipment to make masks, some of them hopefully even N95 quality masks. So as all of the states continue to work through those problems, a couple of other problems continue to loom large. One is a portal. So how does a portal manage tens of thousands of new cases, new requests coming in, I want the test? And yes, you can only do it if then. And how do you program that in and not crash your site? There's a lot of that going on right now. And of course, then there are the political challenges. There's the executive branches of government responsible for setting up solutions, and other branches of government who may not be, well, you know, who may be critical and frustrated for a whole bunch of reasons. There may be political history. There may be just be frustration that we want a solution now. So, tier 1 only. Okay, what's tier 1? Well, if you start looking at some of the basic question programs that the association, ASTHO, Association of State and Territory Health Officers, plus a couple of other national groups, they're agreeing on a form similar to this. It starts off fairly clear. Person information, the name, date of birth, age, gender, race, address, county, etc. So that's all pretty clear. And then we get into symptoms of COVID-19. Do you currently have these symptoms? Fever greater than 100.4 and cough or shortness of breath. So what do you do with that? Well, automatically we're starting to get some confusing logic and or A and or B, A and or C. That's okay. Let's put that aside for a second. And then we get into section 3, which meets the prioritization for tier 1 testing. Check all that apply. Now let me go back and give you the my a little bit more simplistic interpretation of what tier 1 means, as I have been reviewing the CDC site and recommendations and these sites as well. There are three basic criteria within tier 1. One is people that have, they're in the hospital. They have COVID-19 and they're in the hospital. Well, that's clearly not a question for mass testing sites. They're in the hospital administration, the doctors that are taking care of them are going to be doing the COVID-19 testing. The second group within Tier 1 is the healthcare workers that are providing care to the people that are in the hospital for COVID-19. So again, fairly simple group, but really not an issue for outside of the hospital testing. 1 and 2, the patients and the providers of healthcare for people in the hospital, that's all going to be done by the hospital. Now, what does that leave? Well, that's again where it starts to get a little bit murky. A greater than 60 years old who has symptoms of COVID-19, currently living or working in a congregate setting, independent or assisted living center. Now, what does that mean? Do you need both of those or just one of those? Because if you go back to the CDC symptom checker, if you're over 60 years old and they say, if you have difficulty breathing, you're blue in the face, you have massive chest pain, don't go get a test, go get emergency care. Or if you're losing consciousness and things like that. So again, if you fit those criteria, don't get a test, go get emergency care. Then the next thing they say on the CDC side is if you are over 60 and you don't have difficulty breathing, but you've got fever and maybe cough or shortness, a little bit of shortness of breath, then stay at home, talk to your doctor. So as you can see, there's 3 criteria within Tier 1. The first 2 are really clear. They're being done in the hospital. The third one gets a little bit unclear, and that's where you start saying, we're having major challenges standing up these portals, standing up sites which can actually do the appropriate triage for mass COVID-19 or coronavirus testing. Sorry about that. I wish it was a lot clearer, but again, that's above my pay grade at this point. I'm going to go out, escape there and see. Well, I thought I was going to escape and go back out and see if we have anybody out there or if we've disconnected again. Okay, we do. We've got a lot of people out there and a lot of questions. Let me go back up, start dealing with some of them. So, James Robert Clark III, excellent. I take vitamin C, glycine, and glutamine, as well as quercetin and citrus bioflavonoids for asthma, and it works very well. I'm not telling anybody to do this, but it works for me. Thank you very much, Mr. Clark. Many of these substances have antifibrotic and antiviral properties as well. And that's me saying there are no tech challenges yet, but obviously it was. Still early, we did go down for a few minutes. John Panazzo, excellent topic. Looking forward. Nancy DeBozic, hi doctor, I'll attempt to keep from pocket dialing today. Thank you, Nancy. And again, I don't think it was much of an issue even when Nancy's phone was in her pocket and it was evidently doing some dialing, pocket dialing, but it wasn't dialing, it was writing pocket comments on our on the YouTube Live a couple of days ago. No problem. Thank you very much for your interest. Hello from Germany. I hear that Germany's doing fairly well right now, and the German authorities have attributed it to 2 things. Number 1, a lot of testing and quarantine of transmission clusters. And number 2, some really good luck. Excuse me, I hope that both of those processes continue. I hope you continue to have the ability to do a lot of testing, find those areas of transmission and continue to cap those off. And most importantly, I hope you have good luck in doing this. Tab Tigrig, good morning all. Thank you, Tab. Good morning from Martin Ortiz. Greetings from the People's Republic of California. California's got some challenges cranking up. Obviously, New York is the epicenter. New Orleans probably would be because of some of the misbehavior down there. It's just that they're not nearly as big as New York. So New Orleans appeared to be, at least for a few days, the most rapidly growing site, or the highest number of cases. I can't remember which, but I think it's becoming eclipsed very quickly by New York, and we're all looking for LA and Chicago and some of the other population centers to start cranking in. Carnival, is there scientific proof that this CV exists and causes disease? I'm assuming you're saying coronavirus. There's clearly plenty of scientific evidence that it exists and that it causes disease. There's a pandemic going on out there with it. Okay, Greg Clopton, JAMA Cardio has Wuhan report on COVID-mediated cardiac damage, including elevated troponin. Yes, it does. It does appear to have some damage to the heart. Now, the question is, how significant is that in the big picture? Right now, I don't think it is. We may find later on that the people that survived through the COVID-19, bad disease. The COVID-19 is the bad disease. The coronavirus is the virus that causes it. We may find that people that make it through the acute care, the acute bad disease part, actually end up with scars in their lungs, scars with their heart, stuff like that. But it's just too early to know that right now. It's not unusual. It's not unusual to see people that have gone through sepsis or going through sepsis and ARDS, acute respiratory distress syndrome, to have some of this kind of damage. It's multi-organ damage to kidneys, brain, heart, etc. Bill Gifford, good morning from Estero, Florida. Good morning to you. I think maybe I forgot to mention Miami and Florida as an upcoming major epicenter. Mike Martyr, here's what Korean version of Fauci said. Subtitle, and most of what's important in the last 10 minutes. Okay, so here's the stringer watch. Maybe, Clyde, we can review that this evening and see if we can put that up as one of our video components. Clyde has developed, by the way, continues to develop some very interesting technology. He showed me this morning that we'll be able to actually show some videos as part of the YouTube live program. So Janice was wanting to do some. She got a lot of great reviews from her comments about practical living in terms of Amazon packages and grocery shopping. She got good reviews. She liked it. She usually doesn't like doing videos. Now she's saying, you know what, that was not so bad. And she would like to do a few videos where we actually get into a little bit more detail regarding safe physical distancing. And again, the differences between social distancing and physical. Eliza 2020, hello from California. Carnival, why are we assuming the number of cases is remotely accurate when there's evidence these tests suck and people are getting diagnosed remotely? Well, Carnival, I think it, I don't mean this maybe the way it sounds. I think it might be naive to assume these numbers are accurate. But what they are is they're an indicator. And like any other indicator, you have to translate that indicator in terms of what you do know and what you don't know. For example, we knew all of these indicators, none of them ever showed there was transmission going on 2 weeks before the outbreak here in the US. But we know, based on everything else that we were seeing, that yeah, that's what happened. We've been having the transmission appears to, clearly based on the science that we have seen so far, transmission is happening a week or two before these cases start breaking out. So Again, the assumption that these numbers are exact truth is like, I mean, you can't assume anything in life is truth. You have to start, I mean, pardon me, I'm going to start getting into Kantian philosophy here. You have to take the information that you have and start piecing it together. I hope that helps. Paul Lassa, Mike Martyr, do you get to that link? Eliza 2020, why are the number of deaths in Spain and Italy higher than in China? Well, I don't know for sure. I have some suspicion that China is maybe significantly underreported at this time. I'm a little bit skeptical that Spain and Italy are actually higher than China. And again, that gets back to that other point. Don't believe the numbers. Put the numbers together as indicators with facts that you already know. For example, China has not been the greatest in terms of reporting anything to the rest of the world. James Cantor, in mass testing, would not too many people be tested, i.e. people who are just worried? Absolutely. And that's what the problem is, especially in this time. You know, a lot of what I've said sounds like criticism of the CDC, criticism of state and county health officers. Not at all the case. If I were playing one of those roles, and I've been very close to those roles in the past, I've trained a lot of people that went into those roles, I'd be probably doing exactly the same thing. I think I would also be doing something that I see a lot of them doing. Number one, be very frustrated with all of the information and all of the overactivity that's coming through their offices. They have tons of people requesting to help, wanting to do things that they think they might get wealthy with, other politicians, constituents, etc. One of the major focus, and in fact, one of the major, most important things you can do is continue to communicate. The Kentucky governor, by the way, has been doing a great job. He's got a daily fireside chat kind of thing. He goes onto the TV about 5 o'clock each day, Kentucky time, and gives an update on what he's seeing in his office. So, yeah, it's there would probably be too many people tested if they just said, look, anybody that wants to get a test, go get one. And in fact, that's already happened in many places that have set up testing. They've gotten overrun. And so it gets back to the point I said a few minutes ago. The reality is we don't have enough tests. The next reality is the testing is important to get a better handle, better indicators on where transmission is happening. So how do we set up a system which deals with both of those issues, and the issue that the minute you set up and you shop and say, we're going to provide testing to the public, you're going to get trampled. And so far, most of these operations have gotten trampled. We're doing a lot of work right now to stress test our systems to make sure that doesn't happen. A. Ballard, 527. Why are people going into cardiac arrest with COVID-19? Is it triggered by a decrease in oxygen in the blood? Yeah, so again, you get multi-organ failure of kidneys, failure of lungs. And again, with most, and I'm talking about just with sepsis and ARDS, and it's very similar to what you're seeing with COVID-19. By the way, I'm not an ICU doc. I've spent my time in ICUs, but that was many years ago. The bottom line is sepsis has not changed. It still causes multi-organ damage. The circulatory systems shut down. The ability to ventilate and oxygenate shut down. In fact, when you look at some of the studies that have been done, one of their criteria is the pressure of oxygen. I'm sticking up my finger because we've got a simple way of looking at, it's called a pulse oximeter. You put it on the finger and you can tell what pressure of oxygen folks are able to create. You and I, those of us who are not significantly critically ill, are going to have an oxygen level or a PO2, pressure of oxygen, 95 and above. 93 and below, you've got very significant problems. So does that hypoxia, is that what's causing the cardiac arrest? In a lot of cases, yeah, it is, but there can be other things as well. So I hope that helps. I hope that gets you. And yes, very soon after we got started, we lost the video. There goes YouTube. Where did you go? I didn't go anywhere. YouTube shut us down again. John Tucho lost the video. YouTube is another fatality. Yeah. Doc's trying to get a little too fancy with his production value. Well, no. Paul, I appreciate your suggestions. And let me just tell you, you're not the only person that's giving me a whole lot of criticism, especially about my production value, production activities. And I'm going to leave it at that. If you want to talk about my production on my videos at some point, make comments on the channel. Ben Herman, yes, what? Yep, what? Yeah. I just came back. Well, yes, I did. Again, we're back. Yes, 30 seconds ago, Arnold. The show must go on. Okay, from Chris Masterjohn, vitamin C could increase interferon, which in SARS is the trigger for the cytokine storm that causes inflammation in the lungs. Suggests not using high-dose vitamin C as a supplement. Yeah, I've seen a lot of Chris Masterjohn's stuff, and I think that he's a very interesting guy, and I'm a big fan. In fact, listening to him is what got me started on betaine or betaine, the methyl donor supplement, which if you have questions about that, you can go to some of my other videos about that. Richard, thank you. You hear me in California. Sepsis, you're back. Yes. I've seen indication that those with diabetes, type 2 diabetes, are the most likely to succumb to complications from this virus. The numbers are small, but very strong. Thank you, Dr. Brewer. Yes, and that's Thomas Gronek. So Thomas, yes, that's a big, big deal. And if you look at our channel started 4 years ago, and it was focused on people that have diabetes and especially unrecognized prediabetes. As you'll see, if you start scrolling through the comments on our channel, 2 or 3 times a month, somebody says, you know, Doc, I decided to start taking your test. They're talking, most of the time when they say this, they're talking about an insulin or an OGTT, oral glucose tolerance test, and even an insulin survey. If you haven't heard of insulin survey, it's an oral glucose tolerance test, but you measure insulin as well. You can look up Joseph Kraft, K-R-A-F-T, insulin survey. And here's what you find. And here's what the majority of my practice and the majority of my channel is. People like that saying, I don't have prediabetes, I've got full-blown diabetes. And my doc's been telling me every year, I'm fine, I don't have a problem. So that's the thing. We've got, if we think we have an epidemic of obesity or an epidemic of diabetes, we haven't seen anything yet until we start looking at the epidemic of undiagnosed prediabetes. Now, why did I go there? Number one, because that's a major component of this channel. And number two, what you're hearing from the CDC right now is you have significant risk if you have full-blown type 2 diabetes with complications. That tends to be the continued gospel that you hear in medical circles. The bottom line, though, is this. Prediabetes is the very, very same disease process. It's just a matter of degree. The difference between prediabetes and diabetes is a blood sugar of 190 is still prediabetes, but over 200 is full-blown diabetes. A fasting blood sugar of 120 is still prediabetes, and over 120, 126 is full-blown diabetes. So that's the difference between prediabetes and diabetes. And you say, well, it's clearly a matter of how much damage it's doing, right? And prediabetes is not doing damage. It's not messing up your immune system. It's not putting you at increased risk for COVID-19, et cetera, right? Well, go back, take a look at the science that we know about tissue damage in prediabetes. By the time people get a diagnosis of full-blown type 2 diabetes, between 1/3 and 2/3 already have diabetic damage to their eyes. And about 1/3 already have some evidence of neurologic damage, nerve damage. So 1/3 of what you would see with full-blown diabetes. So the point is, yes, there are a lot of us with prediabetes. And no, having prediabetes instead of full-blown diabetes really doesn't mean that you're safe. You need to be aware. Now, what portion of people are aware? Well, when you look back 5 or 6 years ago, the CDC was saying there are about 80 million, about 1/3 of adults in America have prediabetes. And according to the CDC at that point, only about 8 million knew about it. So 90% of us that have this disease process prior to full-blown diagnosis, full-blown type 2 diabetes, only 10% of us know it. Well, there's very good reason now to believe that those numbers are way low. If you start looking at the UCLA study, for example, they said it's not 1/3, it's 1/2. And it's not starting at age 60, it's starting at age 30. And even the UCLA study it just looked at fasting blood glucose and hemoglobin A1C for the most part. Most of the people that are responding on this channel and saying, I've got full-blown diabetes or I've got way significant prediabetes, they have been followed already with hemoglobin A1C and fasting glucose. So there's a significant epidemic of prediabetes out there. There's plenty of evidence that prediabetes injures your tissues, like your retina, your eyes, your nerves. So who's to say that prediabetes doesn't cause increased risk for COVID-19? I certainly wouldn't put my money on that. Paul Lassa, he's back, guys. Lay face down is pneumonia. Not sure what you're talking about there. I think you may be meaning that once you get into acute respiratory distress syndrome, they have found a few things that greatly improve your survival in the ICU. And again, somebody fact check, somebody help me in terms of it's MedCram. They've got some really good stuff for those of you that want to get technical. A couple of months ago, MedCram covered some of the recent developments in terms of managing sepsis and specifically ARDS, having people on the respirator in ICU. And I think he specifically did go into some mention about COVID-19. So what happens with COVID-19 in your lungs is your lungs get inflamed. The air sacs or alveoli, the space around those air sacs becomes flooded. So that extra water sort of pushes them in. What we find that we have to do in the ICU is blow those sacs open. The problem there, that helps immensely. That takes a mortality rate from 42% down to about the mid-30s. But the problem that happens next is that if you use pressure to blow that alveoli completely back up, you cause more inflammation. So they have to they do minimal level. Now, in order to do that minimal level, your brain doesn't trust that. So your brain is fighting the ventilator. So they have to paralyze you. And as Billy the Weasel said a second ago, I think this is what Billy was talking about. They have also found that flipping you over on your stomach for this is a significant improvement in mortality. So you do those three things: flipping them over on their stomach, doing the the lower ventilation levels, the lower tidal volume levels, and the paralyzing you. Those three things take a mortality rate in the 40s down to the mid-teens. So significant improvement there. And again, it might be better to go to some other channels and check details on that. Andrew Wilkinson, have you seen the story of almost all people with severe cases of COVID-19 being diabetic or pre-diabetic? I haven't seen that. I would love to see it. Andrew, please send us that that connection, that link. As you may have heard from me over the past few minutes, I'm very concerned about that. Thomas Gronick again, vitamin C theory corresponds to high carbohydrate intake, as carbohydrate clogs the GLUT4 receptor and incapacitates it from transporting vitamin C. Billy the Weasel, IV vitamin C in the US. They're LOLU. Vitamin C is the king. Daniel Christopher, true. And NAC, N-acetylcysteine. That's another supplement that very popular supplement. Actually, we used to use N-acetylcysteine for Tylenol overdose. Different topic for a different time. Ascorbic acid or whole vitamin C? Again, another debate that I'm not going to get into today. Richard Lund. Hello, Richard. Long ago, Mayo Clinic tried polling protocol, but by mouth, not IV, and the issue was dropped. And a lot of people would also say, well, you can't get enough by mouth. You can't absorb enough by your GI tract. Other people would say, look, they're talking about small doses. They're talking about a few 100 milligrams. Then you really have to give 2,000 to 6,000 grams or more. And again, those are the kind of doses that they've been using in these recent ICU treatment studies. Are all the deaths deaths taking place now in Italy only because of COVID-19 and not because of influenza-like illness? Well, I think that's a good question. And again, it goes back to looking at numbers with a healthy skepticism. Especially like older folks are being killed by other types of influenza, or by influenza right now. Other types of viral diseases. Now, if you're an older person and you come down with a viral disease, it turns into a pneumonia and you die, you would hope that they had tested and documented that before they attribute it to COVID-19, but are you sure? And if it's not, my point is, again, you have to look at all data skeptically. At least 20,000 people die in Italy due to IFI every year. I think IFI, you're talking about seasonal flu? By the way, somebody sent me a very interesting comment about flu. Said that this past year was there were 80,000 deaths due to flu. Huge increase, the biggest amount since we've had since, gosh, decades. I think they said the second biggest one was 56,000, 57,000, back in the 60s? And clearly the biggest number we've had since 1918, the Spanish flu. So again, significant flu season this year. The great Billy the Weasel, the great Dr. Pauling used ascorbic acid molecule, not whole C. Mike Martyr, more alive than dead, sells me. Dose of C and duration is obviously important. Stay tuned to New York. Take your 2 grams with food. Thank you, Mike Martyr. That's exactly what I'm doing. Ben Herman's 20,000 is the US number for flu. Now that is interesting. I need to go back and do some fact checking. Was it 20,000 this year or 80,000? Obviously, very, very different numbers. Ben is right in my humble opinion, not Italian. Robert Simpson, hello. So let's see if we have anything else that we should be responding to. Otherwise, we will wrap it up. See if we can get it to less than an hour today. 8,000 deaths and going up is still staggering for Italy. They did not test everyone. You had to qualify. If you did not qualify, you could pay $140 US dollars. Great video on Asian boss. Political challenges, end quote. Italy has only 60.5 million people, not 300 million like the US. In South Korea, Dr. Kim was from. Okay, I think we're getting a lot of conversation. I'm not seeing any, I'm seeing mostly quips and conversation, not anything that I think I can really help significantly with. We've had a lot of interest today, a lot of comments, a lot of participation. I thank you so much for that interest, and we'll continue to do. We've gotten a little bit frustrated a couple of times that the work that our teams are doing in prepping for some of these, and you look at some of the other folks, and they'll put stuff out, but maybe not the greatest content, but get tens and hundreds of thousands of views. The thing is, we're geeky and can be fairly boring. But the thing is, we do get thousands of views. We get thousands of people that are very interested in what we're talking about. So as for me and my team, we're going to continue plugging. Thank you so much for your interest.